Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan. Now, here is your host, Joe Steckler.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is coping with stroke issues. Joining me for the discussion this morning is Dr. James Kearney, Doctor of Internal Medicine with the Medical Associates of Brevard. Welcome, Dr. Kearney.
Well, thank you.
It's a pleasure to have you on the show for several reasons. First, you were my doctor when I came here several months ago after having suffered a stroke. And the decision was made to move me from the Woodstock Hospital here to HealthSouth Sea Pines Hospital. And you and Dr. LeBron were my doctors here. And I discussed with you at that time the feasibility of doing a show on strokes and what we could do better, what we do wrong, how we could improve, what are the risk factors, what is a stroke, and you said you'd be willing to do that. So
Certainly.
we're here today to do that. We're going to do two things. We're going to do a separate 28.5-minute show on stroke and coping with stroke issues, but then we'll lift parts of that to put back into our stroke series because you were so excited about putting together something that people could sort of wrap their arms around and see what is a stroke, what happens, how can we recover? And having said what I said, as a doctor, what do you see as some of the greatest issues that, unknown issues that we have to cope with in dealing with strokes?
Well, that's a very good question. Strokes are insults to the brain, usually caused by a clot forming in one of the small or medium or even large arteries of the brain, interrupting flow of oxygen, blood to that area of the brain. And it will actually destroy that area of the brain, and that can cause significant damage to our neurological systems. It can cause death, it can cause loss of consciousness, it can cause loss of use of a side, of an extremity, of our speech, of our vision, and often multiple aspects that can occur. And it's important to understand that often a major stroke is preceded by warning signs. And acknowledging that we have these warning signs and not dismissing them as part of normal aging, I think it's very important. And those warning signs can be a significant, brand new, one-sided headache, can be sudden loss of vision, can be sudden difficulty with slurred speech or difficulty with word finding. It can also be loss of use of an extremity, numbness of an extremity or numbness of the face, sudden loss of consciousness for no explanation. And these transient neurological deficits need to be addressed and addressed urgently because we may be able to avert a stroke by early intervention.
But what do you do with somebody like me?
Mm-hmm.
I had what is it, hemorrhagic? Mm-hmm. Mine was outside the brain.
Mm-hmm.
Was my stroke a major stroke or not?
Well, we discuss major on several factors. Number one, how much of the brain is involved. And number two, how much neurological deficit a person develops as a result of that stroke. So I would say, yes, you had a moderate to a major size stroke. And some of that was the deficiencies that occurred, with your arm and leg, and the required rehabilitation for that. And some of that was also the size of the hemorrhage that you had.
Yeah, but I didn't have any paralysis. My speech, my wife at times picks up a little slurring, but if I concentrate on it, I don't think we notice it as much. My memory seems intact, except for the fact, and you mentioned weakness in arms, maybe something on the side of your face or slurring your words, right? But I had none of that I can remember. I don't remember anything. I remember I walked my physical therapist who had given me my last treatment for my back. I remember letting her out the front door. And the next thing I knew, I was in the intensive care unit at Woodstock with a tube shoved down me. I had no pain. I had nothing.
And Joe, you're also being very modest because you've gone through and done very well and cooperated with and participated in fully a rehabilitation program. And so some of the deficits that you started with, you've made tremendous advances on. But to get back to your first point, yes, there are some individuals that have no prodrome. They really have no symptoms which come on. Certainly, if you do, those need to be addressed, but there are individuals like yourself where this occurs suddenly and without warning. And that's what's devastating about a stroke, is how quickly it comes on.
Yeah, I just, I spoke to a group of people about my stroke. I was asked to do this at a Naval Academy luncheon a week ago. And as I walked up to the podium to give a short talk on my stroke, it turned out that the president of our association had a mini stroke just a week before, and he went straight to the hospital because he had a weakness in his arm. He had several things he didn't think were right, and he went to the hospital, and they kept him for 4 or 5 days, but he was okay. But I told you when you saw me here at HealthSouth, I said, this has happened to me. Now, what can I do to make this experience something positive? How can we turn this around so other people can see the value? And you mentioned a rehabilitative hospital and a team approach. You're right. When I was going through therapy here at HealthSouth Sea Pines, before I left the hospital, we shot about 4.5 hours of film here with me doing my exercises. And as I look back 2.5 months ago, yes, I very visibly had a stroke. I could tell that I did not have the energy then that I have now. And that goes back to what you said about the value of rehabilitation. And perhaps you can help our viewing audience understand more about what a rehabilitative hospital can do and what you have your own private practice, but you also have patients here in this hospital, but you also treat HealthSouth patients here in the hospital. So I would like to have your take as a doctor of internal medicine and what you see and how this whole process works.
Well, and I'm excited to hear about your colleague receiving medical care early, and when he had this transient neurological deficit, and he may have averted a major stroke by medication, by further investigation as to perhaps why he was having these symptoms and correction of that before a person develops a stroke. But the situation you found yourself in, and thousands of Americans find themselves in every year, is you've had a stroke. Now what do I do? And one of the things that we have found is very helpful, and this is after decades of research and collection of data, is early intensive therapy, physical therapy, occupational therapy, speech therapy, to work as soon as possible as the person is medically stabilized and able to be transferred out of an acute care facility, an inpatient setting with multidisciplinary specialist approach is a very effective way of combating the multiple deficits that an individual has. For example, here at Sea Pines, we have a full team staff and large amounts of equipment and expertise in physical therapy. And so an individual, for example, who may have balance instability, who may have weakness of an arm or a leg, immediately will begin to work on retraining, as best we can, the uninjured part of the brain to take over that function lost by the insult of the stroke. Occupational therapy, dealing with fine motor movements of the hands, for example, that we need for signature, to do our job, to use our keyboards, that type of thing. Speech therapy, individuals who have lost their ability to speak or have slurred speech. Another common condition is problems word finding or word substituting, where an individual says a word they don't mean to, like today I went to the balloon instead of to the store. And a patient, very methodical speech therapy program has been proven to have significant advantage to individuals who have had difficulty with their speech after a stroke.
When you address that just for a second on speech therapy, I didn't seem to believe myself that I had a problem with speaking, but as I worked with the speech therapist here at HealthSouth Sea Pines, I noticed, and she pointed out to me, that I was skipping words. So what she wanted me to do was focus on the left side of the page to see if, I guess, the right side of my brain was working, and then she had me do this to see if my left side was working. And she detected a slight difference between my left and right side of my brain and how I was reading. So just in a couple of sessions of concentrating on what she had me concentrated on seemed to make the problem go away. And
Yes.
I probably never would have figured that out myself, or I would not have realized I was doing that, which again points out the advantage of having of a rehabilitative hospital team approach to physical rehabilitation.
And you said it yourself, the first several days of admission in a rehabilitation program, a very intense rehabilitation program, focuses on evaluation. What exactly did this stroke do to you? What did it do to your arms? What did it do to your legs? What did it do to your speech, your manual dexterity, your vision, your ability to perform what we call activities of daily living, get in and out of a chair, in and out of a bed? And all of that needs to be assessed. It's something we don't think of, but when we get home, if we didn't go through such a program, would become very obvious to us that we had a significant issue. And so evaluating those issues and then sitting down as a team and discussing what process we're going to do to reverse or address those deficiencies as best we're able is a good approach.
When I was here, and did you participate in any of the team conferences for me?
Yes.
What can you remember about how the team discussed about my progress?
Well, the team approach is an ongoing process. It's dynamic, and it begins with usually a first team conference where we discuss the assessments. Each team member, the physical therapist, the speech therapist, the nursing staff, the physicians, begin to discuss what deficiencies they see, what the proper treatment approach needs to be, and the nurse may communicate that to the physical therapist. The physician may communicate that to the speech therapist, for example, if a person's having trouble swallowing. And then begin a treatment plan based on the deficiencies and needs in that discussion. And the other important issue is that the physician and nurse are also very important parts of this plan. Complications after a stroke, pneumonia from inability to swallow, falls with fractures can occur after a stroke. And so it really does need to be a multidisciplinary team approach. But then we would meet again, and as you would make advances on your arm and leg strength, we then say, well, you know, I think maybe the next several days he's going to be able to start to stand on his own with a little bit of supervision. He's going to be able to get out of the bed on his own, and then allow you to do those things, obviously being closely supervised, because those are activities when we get home and live our daily lives, we need to be able to do.
Yeah. So. I know it's been roughly 2 months since you really saw me in the hospital, and you see so many patients, it would be unfair for me to try to pinpoint you, but do you remember one of my greatest concerns was, will I experience another stroke, or how would I know if something like this is going to happen to me? And I asked you that question and asked Dr. LeBron that question, because that was something that just, since I didn't know anything was happening, I tried to figure out what would I do? And I don't remember what you said, but I remember Dr. LeBron said, if you get the worst headache you've ever had in your life, Joe, he says, head for the emergency room immediately.
Right. I think that's good advice. And you did mention that here we are 2 months later, and here you sit here doing a television interview with me. And that just, to me, that's wonderful. That just fills my heart with joy, because I know that this is your passion and your profession, and here we are doing that. So that's the goal of our rehabilitation program, is number one, to try to get an individual to become independent. Number two, to be able to, take care of themselves, feed themselves, but then get them back to their profession, get them back to what they love to do, get them back to supporting their family. And that to me just is wonderful that you and I are sitting here. As far as what you need to be concerned about in the future, certainly neurological deficit, which wasn't present before, but is present now. And as Dr. LeBron mentioned, a new and unusual headache are things that you have to watch for. Your medications have been changed now. Your risk levels have been dropped by that. You're being followed. And so, we're going to do everything we can to make sure that this never happens to you again. But I'm excited that you're using your experience to educate others, so that perhaps they can seek out medical care.
Well, I think it's important for people to realize that we not only have a team of doctors directed towards helping people recover from strokes, but what we got a thing I put in here, and I called it the importance of the patient's own medical team. As a medical doctor, a doctor of internal medicine, what would you tell our viewing audience about some of the things they can do right now to lessen their own risk factors or improve their chances of not having a stroke?
Well,
take that first.
This show would be a perfect opportunity to do that. You realize how hard the road was, how time consuming, and if we can avoid stroke, I think that's really a much better avenue than attempting to fix the damage done by a stroke. And the things which our viewers need to understand is smoking increases the risk of a person having a stroke. Obesity, there are studies which have suggested that. High blood pressure, uncontrolled diabetes are all issues which increase a person's propensity towards stroke. Family history of stroke may show a slight increase in risk. And so stopping smoking, losing weight, staying active, making sure someone's checking your blood pressure, making sure someone's checking your blood sugar are ways that a person can preempt this from occurring and prevent a stroke.
Okay. Another thing that I don't think that patients talk to their doctors about, and I'm not sure how much the doctors think about it in talking to their patients, but they use the word depression and risk and stress. I've had so many people say, Joe, you're stupid for pushing yourself and doing these things. You're going to cause yourself to have another stroke by pushing yourself. I don't know how true that is. And I don't know if by pushing myself that I help lessen my chances of having a stroke. I don't know how to put all that together. I try, and I try to say, maybe it would be smarter for me to train the center line like we do with the gun mounts on the ship and secure. But I can't do that. And
well, we don't really have any significant medical evidence that depression, for example, increases a person's risk for stroke. Stress is a difficult subject
Yes.
in that sometimes when we're under significant stress, our blood pressures go up. But having your blood pressure monitored, certainly if there's a propensity for you to have high blood pressure readings, reducing your sodium intake, which is a huge factor at reducing high blood pressure, reducing your weight, and seeking out medical attention, perhaps having to take medication to keep the blood pressure down. But stress in and of itself, other than perhaps its negative impact on blood pressure, is not something that we ordinarily would reduce in an individual's life. And that's a very subjective thing, stress.
Okay. I have, and I've had for 25 years, a thing called atrial fibrillation, which is a risk factor for stroke.
It is indeed.
Yes. Since my stroke, I take my blood pressure morning and night. I take my blood pressure before I ever take my blood pressure medication. And I find many times that I get way off the chart readings, and I try to sit there at least 5 minutes, and then I've had a nurse tell me the recommended time is to wait 15 minutes before you take your blood pressure. But I find that sometimes my blood pressure can be 150 or 160 over 92, 94. And if I sit there and wait, it did this morning, wasn't quite that high, but I waited about 4 minutes and it dropped down to 126 over, it was 72. And my heart rate was 64.
Well, and your experience is actually not uncommon. High blood pressure currently is defined as 140 over 90 or above. And there are some exceptions to that rule. In the elderly, I won't put you on the spot, but if someone's over 75, that they're a little bit more lenient with you. 150 over 90 becomes the goal. And unfortunately, those with diabetes or other risk factors, actually, they don't get the 140 over 90. Their goal becomes 130 over 80. So depending on the population we're dealing with, the goals of the blood pressure to be achieved are different. And we do recommend 3 different readings. It's difficult when you're working like you are and meeting deadlines and schedules to spend 15 minutes in the morning and evening taking your blood pressure. That's going to be a difficult thing to do. But taking at least 2, maybe 5 minutes apart. If you continue to get high ones, maybe another one 5 minutes after that. And making sure that on your doctor visits, you bring a log of your blood pressures with you. The physician can then react to that. Individuals may, for example, have higher blood pressure a specific time of day. That may be related to what they had eaten, and it may also be related to how their medications are timed and dosed, and the medication may be wearing off or may need to be increased or split into several doses. So those are decisions that you and your physician can discuss in managing your high blood pressure.
I have found since my stroke that I had and I have still good relations with my medical team, and I try to understand why they have me do what they have me do. And my cardiologist nurse called the other day and wanted me to check my heart rate for 4 or 5 days and get back to her. and my heart rate is about the lowest it's been is about 64, and the highest around about 78 for a period of 3 days now, which I think is a good heart rate. But what is the importance, following a stroke, what's the importance of the heart rate?
Well, unless it becomes very low or very high, probably that's not a very significant factor. Certainly in atrial fibrillation would become concerned when the heart rate is rapid, and perhaps that was the purpose of her phone call. But as far as the heart rate being a risk factor, other than it being irregular, as it is in atrial fibrillation, we really don't have data suggesting that having a heart rate too high or too low is related to propensity towards stroke.
Okay. And we don't have a lot of time left, but I do one area I would like for you to talk to our viewers about is your assessment of quick treatment and what I would call sufficient follow-up.
Well, the new emphasis and some of the great new things which are occurring in medicine have to do with treatment very early in the stroke, with new data suggesting that the administration of some of these strong intravenous anticoagulants, blood thinners, if an individual doesn't have contraindications, has had significant impact on really reducing the amount of neurological deficit an individual has. Stent placement, and this is hot off the press now, which is occurring in the arteries of the leg, occurring in the arteries of the heart, is now occurring in the arteries of the brain and in the neck. And so I see over the next several years the ability to quickly and dramatically intervene, but there is some dependence on the patient in that situation. The patient needs to recognize that they're having a neurological event and needs to get there quickly.
Yeah.
That's the issue.
You cannot err. It's better to err on the side of being too cautious rather than erring on the side of not paying attention to what your body's telling you.
In regard to stroke, I couldn't agree with you more. That's correct.
But I think, Dr. Kearney, that too many people don't appreciate what your body is telling you.
Well, and often symptoms are dismissed as normal signs of aging. You know, I'm getting older, so I guess my arm should go to sleep once in a while. Maybe I slept on it wrong. Maybe my slurred speech is just a passing cold. And we try to kind of justify and simplify our ailments. The difficulty is that may prohibit us from taking an early intervention approach in a pretty devastating illness that we ourselves have some control over by seeking out medical care. And you mentioned one other issue, and I just wanted to address that as well. Follow-up. It's just so important after stroke to continue to follow up with the medical team to make sure the risk factors which were present, high blood pressure, atrial fibrillation, those types of things, are being addressed, and that your physical therapy, speech therapy, occupational therapy are progressing, and you're getting back to, because you know our recovery doesn't end when we walk out the door of a rehabilitation hospital.
Right.
It continues in the home.
Okay.
And so that I think is important as well.
Okay. I got to cut you off.
Okay.
We're out of time, but thank you, Dr. Kearney. I
Thank you.
really appreciate it. And I want to thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call us at area code 321-473-7770. For more information on senior care and resources, visit our website at helpingseniors.brevard.com. Be sure to listen to Focus on Seniors on radio station AM 1300 WMEL every Thursday morning at 9 a.m. And also look for us in your Florida Today newspaper, the health section, every Thursday morning for our Focus on Seniors column.